Hello and welcome. My name is Chris from ChristopherHole.com, and welcome to this podcast where we are going to be talking to the back mechanic himself, Dr. Stuart McGill. He is over in Ontario, Canada, and we're going to be asking him 10 questions referring to his book, The Back Mechanic. We're going to be working our way through the book, so you're going to get a nice overview and some snippets of some information that's held within it, but please do remember, these will only be snippets. There is an absolute mountain of information in this book, which takes you from the very beginnings of low back pain all the way through each step of the way to being able to regain good health and good fitness in your back, within your spine, and to some degrees within your whole body itself. So that just brings me to say hello, Stuart. How are you?
I'm wonderful. Good day, Chris. I don't know what time it is in your country, but it's morning here, so good morning or good day.
Yes, good afternoon from England. We are at 5 minutes past 4, and the weather's not too bad here, so that's a big change for England.
The English, your weather is interesting. I see why people talk about it when I'm there.
Yes, it's an amazing conversation. It's a great conversation. So, to begin our podcast, instead of me sort of bumbling my way through an introduction to who you are and the work you've done, could you share with us just a short background into sort of who you are, the work that you've done over your career, and what you're currently doing at the moment?
Yes. Well, I've just retired from the university where I spent 32 years as a professor. And our objective there was to work to understand, first of all, how the spine works as a structure driven by this brain personality human. And then we worked to document different injury and pain mechanisms. And the third element was to work to understand the very best ways to mitigate the cause of pain and desensitize the pain triggers and then build a pain-free foundation. Part and parcel of all of that was to run a research experimental clinic where we would then test the various things that we came up with to see if in fact they worked or not. And they would be on individual patients and also on populations of just average people, occupational groups, and sporting groups as well. Now that I'm retired from the university, I still teach clinical courses to clinicians around the world, and I see back pain patients, but not the average ones. I only see the difficult, challenging cases that have already attempted by seeing, say, 10 or 12 different clinicians, and they failed to get better, or they were unfortunately made worse.
Now, we are here to talk about your book, The Back Mechanic, which is your latest book. And we are going to go through, as I mentioned in my short introduction, we'll kind of work our way through the book, not necessarily chapter by chapter, but we'll certainly pull sort of a client's journey or a patient's journey out of the book to give them a taste of the information that's in it. But I do recommend that whoever is listening to this and gets some value from these questions and these answers and the videos themselves, that they do go to backfitpro.com and purchase the book, because they'll get a lot more from the book itself than the videos that we're doing today. So in chapter 1, you talk about myth busting and separating fact from fiction. And if I'm not mistaken, there are about 18 different myths that you talk about in here, all the way from back pain is linked to having tight hamstrings, to lying in bed is good for my back, all the way to a herniated disc spells the end of a person's athletic career. So it's quite a broad spectrum. But what I'd like to ask you about is one of the first ones that you wrote about, and it's backs can be rehabilitated in 6 to 12 weeks. And me, myself, working with people with back pain, that is a common understanding that they have, and it's very much sort of educating them a little bit more about the back and a little bit more about the rehabilitation process that helps them understand maybe a wider answer to that. So could you tell us a little bit more about the common timeframes that you've found, and maybe what are some common threads that people who have rehabilitated their back quicker, what some of the common threads might be between those people?
Yes. Well, first of all, this notion that backs heal within 6 to 12 weeks is really driven by the medical insurance industry, who pay for back pain disability. And they based it, unfortunately, on the healing time of rodent muscle, which heals very quickly, believe it or not. So it had very little to do with actual back pain patients. In fact, it had nothing to do with them. So there are features of back pain that occlude people's perceptions. For example, discogenic back pain tends to be very episodic. A patient would report, they bent a certain way, they got a stab of back pain, they had to really lay off things, or their back might have been locked up for a few days, and then it slowly dissipated, and they were quite fine again in 2 weeks. They would believe that they had healed. In fact, they have not. The mechanism there is usually a disc bulge that because of movement patterns, and they may have set themselves up by doing too much gardening or too much sitting or something like that, pressurized the nucleus to work through some delaminated collagen that had already been existing in their back. But those combinations of mechanics caused the nucleus just to seep through, trigger the pain and the very rapid inflammatory response, and it takes a few days to wind it all down. So what I'm saying there is that the person was actually in control, but they didn't know it. No one had ever shown them what the mechanism of that acute attack was. They might have simply been just bending forward and flushing the toilet, and they wonder how on God's green earth did they have such a disabling week or two afterwards. If they learned what the mechanism was, they could avoid it. And I've had some patients who've had that description for years, and they never had another episodic acute attack again. So that would be a very rapid, an example of a very rapid dealing with the mechanism. But it all comes back to the patient understanding the mechanism, and that's why an assessment of their pain trigger is so important. But let's take another kind of patient. Say someone who has more of a compressive kind of overload. They've deadlifted too heavy, or they may have been picking up a child in an awkward position. They had a little bit of compressive damage to the end plate of their spines. They may not know this, and nor do they really need to. But the point is that may cause a compressive sensitivity for a few years. And it takes that long for biology to restore their compressive load-bearing ability. And that's just the way it is, unfortunately. And but they need to know that eventually it will wind down. So there's an example of an extremely rapid healing time, although the tissues haven't healed, that disc bulge example, it will slowly gristle over time and become resilient to the original bending and compression mechanism again. And the other one, which was purely compressive, and it may take much, much longer. But the point is there's a whole host of different causes of back pain, but with an appropriate assessment, the person can get an idea of what mechanical items, such as specific motions, postures, and loads, cause their pain sensitivity to grow, and then, of course, they now have an understanding of how to wind them down.
Which quite nicely brings us on to question number 2, which is getting to know your back, which is chapter number 2 in the book. And what I'd like to do in this question is in some way sort of expand and maybe go a little bit more specific on some of the things you just mentioned in question 1, and just talk a bit more specifically about what are common causes of disc herniations, and maybe what are some patterns that you see in those types of injuries.
Yes. Well, first of all, the torso has a ball and socket joint at the top in the shoulders and at the bottom in the hips. But the spine joints themselves are not ball and socket joints. The discs are actually strands of collagen, and they are adhered together with a ground substance. So let's take the person who does a lot of bending and they want to dance and do all these kinds of spine moving things, which is fine. In order to get the movement, they must loosen the collagen to get the flexibility in their spine. That's an adaptation. Now, let's contrast that with a power lifter who has to lift extremely heavy weights. If they had loosened collagen by doing a lot of mobility, they would be at risk because you've now lost the load-bearing ability to extreme levels. So your spine adapts. You can either have a lot of mobility or a lot of load-bearing ability, but you can't really mix the two because the adaptations of the collagen is very different with both processes. So having said that, a disc herniation is a delamination of the collagen strands. So in the average person, the mechanism is usually repeated bending coupled with compression. One of those on their own really doesn't formulate the mechanism leading to a bulge. So it might be someone who's doing a lot of gardening or repeated bending because they've got a stiff hip joint or something like that. And then the strands of collagen become a bit delaminated. Then through compression, you pressurize the nuclear gel in the middle of the disc and it will seep through the delaminations. Now, why do some people get them and others not? Well, as it turns out, there's a great predisposition to this. I'll give you an example. Let's take a very slender willow branch. You can bend the willow branch back and forth and it really doesn't create stress, and the willow branch can survive many, many cycles, no issue at all. But if you took a thicker branch and bent it 1 or 2 cycles to the same amount of bend, it will shatter right away. The reason being the stress stress in a round branch or tube is a function of its thickness. So now when we take a slender person, they can bend and do sit-ups and dance and do all kinds of things with no real stress developing in their spine. But when you take a thicker boned person, say a prop in rugby or a very heavy framed person, and ask them to do sit-ups, that creates much higher stress in the thicker spine than in the thinner spine. And it also turns out that there's a spectrum of disc shape as well. If you were to look down on the spine from the top and slice it transversely, some discs are quite ovoid and others look more like a lima bean. The lima bean shape, which is more associated with a thicker spine, actually gets disc bulges a lot faster than the ovoid spine. So anyway, there are all these personal factors that predispose some people, and some people do inappropriate training. They think that doing sit-ups every day when they have a thick spine will give them core strength, whereas it was just over time loosening the collagen. They would have been much wiser, much more pain resilient, and actually much more athletic by doing, say, a stir the pot kind of exercise where they would place their elbows on a gym ball, their feet are on the ground, and they do circles through the elbows, building the athleticism in their core without mimicking the mechanism for disc bulges. But anyway, most people, when they understand the mechanism of their bulge, they can really desensitize it and learn to move in a way that doesn't mimic the mechanism. Disc bulges don't just happen. They have a very specific movement and load trigger. So I hope that, first of all, gives encouragement to people and lets them realize that a good understanding that comes through an assessment, and particularly as it's described in that chapter, will guide them as to movement strategies to remove the mechanism and allow the pain sensitivity to wind down and get on with life.
And when we get further into this podcast, what we'll try and do is we might revisit those two people, so that big thick prop and maybe a slender more dancer. And when we talk about the core program and the HIT program, maybe we'll try and talk about what might be a good core program for one person and what might be a good core program for the other person, and try to sort of use those two examples as a way of understanding, if you can relate to it whilst you're listening to it, what kind of program that you might need to be doing out in the big wide world of the health and fitness industry. But for now,
may I add a little thought that just came as an afterthought to that, Chris? There will be many listeners who've been told that they have a disc bulge because it was seen on an MR. Many of those disc bulges are dynamic in that they grow and shrink. And, there are some people who say, well, the MR doesn't show pain, which is absolutely true. But you need an understanding of the patient to interpret those images. Radiologists never see the patient, so they never have a context for interpreting the signs that they see on the MR. We've seen many examples over the years where if a person got in a certain position and then we take the MR after 5 minutes, they have a very large disc bulge. And then we take another position and reshoot the MR, and the disc bulge has shrunken magnificently. So it's just proof that they are in control of the size of that bulge and how to get it to shrink or grow and be symptomatic or not. But I just thought, once again, I'd just try and give people encouragement that they really are in control. A lot of these things that it breaks my heart when a clinician says to them, "Oh, well, the pain is in your head," and that just usually shows me that the clinician didn't have the expertise to show the patient the precise cause of whether they had a disc bulge and the associated pain pattern or some other back pain trigger.
And that leads really nicely into the third question, which is chapter number 3, which is all about, is surgery for you? So we've mentioned there that to some degree a disc bulge can be sort of changed within a matter of moments just by changing a position. So on that note, what should people be considering before they start to sort of go down the road of surgery? Who should maybe they be talking to, and what are maybe some questions they need to be asking themselves in order to sort of maintain health before going, I guess, under the knife, as it were?
Well, chapter 3 is really three major components, but the first component is no one should have spine surgery until they first perform virtual surgery. I can give you a statistic because we follow up with every patient I've ever seen. Of all of those patients who've been sent to us and they've been told, I've tried physical therapy, I've been to the orthopedic surgeon, I've done cognitive behavioral therapy to wind down my pain, nothing has worked. The only thing that I have remaining is spine surgery. 95% of the people who've been told that, we get them to avoid surgery. So there's a fairly, I hope, impressive statistic. And we start by performing virtual surgery. Surgery works in a lot of back pain patients because it's forced rest. Can you imagine the patient who comes in and says, "Oh, I have to go to the gym every day and ride the elliptical for 20 minutes, otherwise I'll go crazy." And we'll say, yes, but that's not how you desensitize your back pain. And if you think surgery is going to work, here's what I suggest for you. Let's pretend you had surgery today. You will not be going to the gym tomorrow. It will be forced rest. And then we get the patient to recover as if they were in post-surgical management. And 95% of the time, they will recover and never need the eventual surgery. So that's the first point of the of chapter 3, and it gives specific details of what a post-surgical recovery would be. But the next section is, let's say, and for sure there are patients who will do well with surgery, but what's the risk? If a surgeon says we'll do a multi-level fusion, I would run the other way. What that person has done, that surgeon, is they have not defined very precisely the source of pain, because they are going to cut out the source of pain with their knife. They better be very accurate with, first of all, proving that the structure they're going to alter is the pain generator. But most of them, unfortunately, operate on the MRI. They do not do a thorough examination to prove. Let me give you an example. Let's say there's a bit of a flattened disc at L4, L5 on a person's MRI. The disc will then, the surgeon will then proclaim, we are going to fuse that level or put in an artificial disc or whatever. They're going to direct their knife to the flattened disc seen at L4. And yet, with a thorough physical exam, you will prove that L4 is not causing the pain, even though it looks rather ugly on the MR. It might be L5 or it might be L3. It might be the hypomobile joint with a very full disc. So that will be a failed surgery. So never, ever agree to spine surgery until the surgeon has proven both to themselves and to the patient what the pain trigger is. And if they cannot do that, then I would run once again the other way. I would be very wary of multi-level procedures. But let's take a patient who has very heavy radiating symptoms. They're unrelenting. They cannot find a motion, posture, or load that gives them relief. And they can define exactly the nerve root level. It's at a single level. Those are the people that tend to do much better with surgery. Anyway, there's a little bit of an overview, but the book chapter will guide you through the various steps to make sure that you're mitigating the risk and taking full advantage of that 95% statistic that most people can avoid surgery.
Now that we've sort of explored the one myth, we've looked at some causes of back pain, and we've looked at sort of, I guess, the furthest extreme, which is surgery. What we'll now do is we'll start to, I guess, sort of come out of that trail of thinking, and we'll start now talking about a little bit more in the way of rehabilitation. So the next 7 questions will be centered around maintaining back health and rehabilitation. So that moves us nicely on to chapter 4, which is the rules and guidelines for back health. And there are a number of guidelines. I've got 9 in front of me here. But I'd like to sort of talk about the first one, not only because it's the first one, but also it covers very much a broad range of topics and encapsulates quite a lot. And one of the things you say in the short paragraph is about healthy movement. Now, can you bring a little bit more, I guess, maybe context or a little bit more in the way of sort of everyday movement that people can be doing that might describe what you mean by healthy movement?
Well, again, I must start that answer with 2 words. It depends. What is healthy movement for one person is not for another because of biology and adaptation. So let's take an example of someone who loves to dance. We did a study on Middle Eastern belly dancers who had incredible ability to move their spines certain ways, but not one of those women could do a competent sit-up. They didn't have the strength. And when you have that much mobility and fine control in your back, it's very difficult to then adapt that mobile spine to bear heavy loads and be strong. So you have to choose. So do you see healthy movement for them? They're quite fine. They didn't, as far as I know in our surveys, they had no back pain issues, but then they didn't train heavy loads. They trained this magnificent mobility. So healthy movement for them was dancing, and then they honored biological constraints and just stayed with that. But if we were to take someone else like a power lifter or a rugby center prop, now they must gain load-bearing ability, and it would be very unwise for them to work a lot of mobility into their spine. They'd be much wiser to stiffen their spine, allow it to become a stacked beam, really, and what we would call a thrust line in mechanics. They stack the forces down through the spine to get it to be as resilient as possible. So the mobility there would be in their hips and in their shoulders. So to summarize all of that, there's a biological tipping point. Up to the tipping point, you're building good health. But when you cross the tipping point, you're then creating cumulative trauma and more pain. But that tipping point is very dependent on the definition of healthy movement in that particular person. So I've given the 2 examples of the movement-based person and the strength-based person. But the way the algorithms that we would put together to build a very functional spine requires what are the demands on that person. Well, if they're going to play rugby, we know what the demands are. They have to run, change direction quickly, and bear tremendous compressive load down their spine. So there is a certain algorithm to create and adapt that kind of spine, and it is the polar opposite of what you would want if you were going to be a yoga master or a Middle Eastern belly dancer or something like that, to take the other extreme. So the point is, know the eventual movement goals and then adapt your spine through training for it, and you will find your healthy movement.
Is there, on sort of the back of that, is there a value in sort of developing, so for the thicker rugby player, is there a value in developing not necessarily a lot of mobility in the spine, but a degree of mobility in the spine? More so once they've, let's just say they've retired from rugby, they've reached their mid-30s, early 40s, and they're sort of moving away from the high impact playing rugby. Is there a value in developing a mobility? And also for the dancer, is there a value in building a degree of sort of strength, endurance around that spine?
Well, I would say the answer is absolutely yes, of course, but it's a matter of degrees. So if they're going to retain a lot of mobility, they are limiting the amount of strength training that they should do for that optimal biological function. Just like the rugby player, once their career is over now, and they don't need that massive load-bearing ability, and they want to just enjoy life, throw a ball. Well, again, it depends on the legacy of their back pain triggers. If they don't have triggers, and training more moderately, they will seek the blend of tuned mobility and stability in their body. But you know, it's so interesting when you get to high performance athletes, for example. Some are what you would call an elastic athlete, and there are various tests that we would do to determine, you know, what the elastic fascial potential of their body is versus just straight brute strength versus just loose joint mobility. But we would evaluate all of this and then use that to guide the decision on how to develop the optimal stability and mobility in their spine. You know, look, let's take an extreme example. Let's take a young girl down in the neurology ward at the Children's Hospital. She's got a paralyzed quadratus lumborum. Well, what she won't be able to do is walk. Now, there's an example of insufficient core stability. If she stands on her left leg, and that's the side with the paralyzed quadratus lumborum, no problem. But when she strides and the right leg becomes the stance support leg, and then she swings her left leg, her left pelvis will drop down to the ground and she'll collapse because of the lack of proximal stability. So, you know, if the person's aging and they've lost the core strength and stability and stiffness, they're going to have a difficult time walking. And if we took the other extreme, the person that is so stiff and immobile, they're having stress just tying their shoes, or they're having difficulty getting upstairs, or, you know, in an athletic situation, serving a tennis ball or something like that. So it's a very difficult question to answer without a specific person in front of us. But if we had that person in front of us, we would listen to what they want to do in life. We would then see what their body is capable of the current time, and then we would train the difference within their biological limits. So that's it in a nutshell as to how we would tune their body.
And to follow on from that, we'll move on to question 5, which we then move into chapter 6, which is your self-assessment, which will hopefully, if people are experiencing any sort of aches, pains that we've been discussing so far in the past 4 questions, this may help with regards to administering your own self-examination, which is a part of that chapter. And one thing I thought would be most interesting, because it does sort of encapsulate quite a lot of the self-examination in that it sort of starts it off and sets the precedent for it. And what are some of the essential sort of questions that people need to be asking themselves about their pain and about how to sort of self-examine their back pain?
Well, we begin that chapter with a flow chart, and then we encourage the reader to get a piece of paper. And then on the left-hand column, write down the activities that cause your back pain to get worse. And then write down on the right-hand side of the page what activities do not cause any back pain, and they may even help you feel better. So I'll give you an example. The person might say, I can go walk a mile and my back feels great. And then on the left-hand side, they might say, but sitting at the computer for 20 minutes causes my right calf and toe to go to sleep. So there is. Then I guide them through what are the common elements in terms of motions, postures, and loads that are causing your pain, and what are the common elements of things that you don't get pain from. So there's the first start of the assessment. Then I guide them through 8 or 9 tests, I can't recall now, that put them into different postures, different motions, and different loads. And in those are different levels of stability. And then we see where the pain triggers are. And then as soon as we've created a pain trigger, we change the position, or we change the muscle tuning a little bit, and you will know immediately if the pain sensitivity grows or disappears. For example, a person might stand, go up on their toes, and just drop down onto their heels, which is a compressive load on the spine of about 1.5 times body weight. Then I would say, well, stiffen your abdominal muscles, push your fingers into the lateral abdominal wall, and push your fingers out. Now try the repeated heel drop, and they'll know right away whether the pain got better or not. Now, they might say, the pain just got worse. Well, that shows us that they do not have the compressive load-bearing ability, and that's the wrong stiffening strategy. So we might try, let your belly stiffness go. Let it relax. Now pull down, compress your shoulders down by stiffening your pectoral and your latissimus dorsi muscles. And now try the drop. And they may say, oh, you know what? That just took my pain away. So immediately we're guiding the patient through strategies that they learn right away what takes their pain away. Then, if you did a shear load test on a patient, for example, say a sagittal plane shear, a front to back shear, and then you would know immediately that, I'll bet you that kettlebell swings flare up your back. And they'll say, yes, how did you know? And I said, well, we just mimicked that action, and it caused you a little bit of pain sensitivity. Or the next person, we would find they have no sensitivity that way. They can do kettlebell swings, and it's a wonderful exercise. Or a lateral shear. Consider a Palloff press, which is the person stands, their arms are out in front of them, and they take a cable in their hands that goes off 90 degrees to the left or the right. And somehow the Palloff press has become a spine stabilization exercise. Well, wait a minute. Let's try a little lateral shear load on their spine first in the exam. If that causes their symptoms, the Palloff press is exactly the exercise to cause more pain. But if the person is very laterally shear stable, the Palloff press might be an ideal exercise. So anyway, that gives a little bit of an insight. And I should probably mention a few other things as well. There are systematic barriers to people to obtain spine health. I'll give you an example. We might say that, walking the way you've just shown me triggers your pain, but now let's walk, swinging the arms about the shoulders, loosening your shoulders, walking faster, heel to toe, and then they'll say, yes, that just took my pain away. Walking is now my therapy. But then they say, but I live in an unsafe neighborhood, or at least one that I perceive as being unsafe. I can't go outside and walk at night. So there is a systematic barrier. It's a social force that's stopping them from recovering using that as a tool. So these are all things in the self-assessment that need to go into the consideration of how we are going to remove the cause of that person's pain trigger.
And just to complete that question, when Stuart McGill mentioned that there were a number of tests in the book, they're all there. So if you are in a position to get your hands on this book, it's just a very simple case of working through each page and using each of the tests and answering the questions within it, and then you'll get a much better idea of where the pain is coming from, and sort of bringing a little bit more, I guess, of reality to what Dr. McGill has just mentioned. And that brings us nicely on.
Oh, Chris, if I may interject just one moment there. I wrote Back Mechanic for the patients because people said, I've written my textbooks for clinicians, and low back disorders, the book, for example, has a very complete patient assessment that clinicians should be executing with the patients. But in Back Mechanic, it was the public that asked me to write that book for them. The assessment is a self-assessment, so obviously it's a very simplified sort of essential list, shall we say, of tests. But for the clinicians listening to this, they'd be much better served with the detailed low back disorders textbook.
And that brings us nicely on to question 6, which is from chapter 7. And this is now about a little bit more on what you've sort of talked about with regards to pain triggers. But just could you explain a little bit more about why it's important to remove that cause and remove that pain trigger?
Yes. When a person has a sore knee, or they've stubbed their toe and they keep stubbing their toe is going to remain highly sensitized. Why would someone take a painful back and start giving it exercise and expecting it to desensitize? So the important first step is to do the assessment and understand the pain triggers. Then stop hammering the pain trigger. And that's where we remove the cause of the pain and allow it to settle. So if it happens to be that when they bend forward and no one's pointed out to them that, the way they put their socks on and tie their shoes in the morning sensitizes their back for the rest of the day. And of course, we've documented that mechanism. Stover Snook, who was a professor with the Liberty Mutual Insurance Company in New England in the States, they are obviously trying to remove people from the back pain insurance list. And they took that mechanism and trialed it and found that when people stopped heavy bending, and some people even pull their knees to their chest first thing in the morning, not realizing that they do get a bit of pain relief by triggering the stretch reflex, but not realizing that they just tenderized that pain trigger to be more sensitive for the rest of the day. But when he trialed it on groups of people, it was found to be an effective strategy to help wind down their pain triggers. So There's just an example from the mundane, but I can then use examples from high-performance athletics. You may be, or your listeners may be familiar with jiu-jitsu and mixed martial arts and that kind of thing, where we've been able to restore some high-profile jiu-jitsu careers. These are people who do a lot of heavy bending, and some of them would get up in the morning and force their palms flat on the floor, not realizing that they thought they had to do that to keep the hip and spine flexibility to perform their athleticism, but they were so painful and highly triggered that they couldn't train. So we stopped that as the pain sensitizer and said, just keep that athleticism for the octagon or the training mats, but for the rest of the day, be quite pristine. And we were able to salvage a few careers by giving them pain-free training capacity by avoiding the cause. And then, of course, slowly over time, it settled and away they went. But those are flexion examples. We could go through the same thing in extension or compression or shear or whatever it is. And I'm going to mention one other thing, Chris. There will be people who do not respond to different motions, postures, and loads. Those are the red flags. We've found very sinister causes of people's back pains who didn't respond to changes in posture. And they had a lung embolism or an aortic aneurysm, or they might have had a cancerous tumor, all things that went unflagged. Even though they'd been screened for them, they were never found. But we found them because the people didn't respond to removing the mechanical cause of their pain. Anyway, we can talk about the psychology of that as well, if you wish.
By all means, go for it.
Well, there are trends now where it's becoming more popular for clinicians to believe that telling people the pain is in their head is useful. The most movement-fearing patients we get are those that have been told the pain is in their head. And it usually comes from clinicians who were either incompetent and didn't administer a assessment of their pain triggers, or they didn't know how. So they blame the patient for their pain and say, look, the pain's in your head, just get on with it. Well, not really. These are very solid citizens, some of these folks. And I'll give you one example. A fella comes in and he says the pain clinic says the pain is in my head, and if it's in my head, it means I'm crazy. But I really think it's in my back and in my hamstring. He described it as shards of glass cutting open his hamstrings when he moved his back a certain way. And it turned out he had a nerve trap, which once he understood that, he was able to mitigate the cause quite quickly. But he was on the brink of suicide. He said, if the pain's in my head, I'm crazy. I don't deserve to live. And I said, sir, give me a week. And we were able to show him how to stop the cause. All the fear and anxiety went away. So this is a trend. It will die. But for now, there's too many telling patients that the pain is in their head. It may be exaggerated, perhaps, by certain personality profiles. But once again, when you empower the person to know what's causing their pain so they can control it, it's so interesting. A lot of the associated psychological distress will disappear.
Chapter 8, which is question number 7, where we start talking about spine hygiene. So we can now start to talk about some of this movement confidence, if you will. And in the chapter, you start talking about expanding your pain-free abilities, and you look at sitting, standing, you've got bending, walking, as some of those movements. So could you share with us some tips that you can give people to maintain a healthy spine while bending and walking, so those two movement patterns?
Yes, well, when you look at the movements that are required for daily life, and you've done the assessment and found which ones are offensive and which ones are not, you can start to analyze what's offensive about the ones that cause pain. So, for example, hip hinging rather than spine hinging may help the movement intolerant back. But you mentioned walking. It's so interesting that pain changes the way you walk. When people have pain with walking, typically they have a smaller stride length. They stiffen their shoulders and they don't move their upper torso. So when you measure the loads on their spine with that painful walking gait, the loads are actually higher. They are doing concentric, eccentric contractions through their hips and legs and loading up their back. Now, if we showed them how to loosen up your shoulders, swing the arms from the shoulders, we measure a better storage and recovery of elastic energy through the core. They actually walk faster now, more competently, with less spine load. All of a sudden, walking becomes a therapy rather than an exacerbator. And the interesting thing, I was giving a speech one time to a medical society, and one of the docs in the room, her husband was accompanying her on the medical conference. He happened to be a professor of, I think it was ancient Roman history or something like that. And he said, listening to that, I've suddenly got perspective on the Roman scrolls, because Caesar, over 2,000 years ago, one of his battle strategies was to let the scouts know from the group he was going to attack, who were 30 miles away encamped, let their scouts know on purpose that the Romans were 30 miles away that evening. So the other side would think, okay, well, we can break camp in the morning and escape the Romans. But what he did was he marched his Roman legions through the night, but it was written in the scrolls, heel to toe walking. Stiffer through the core, but looser through the shoulders, swinging the arms about the shoulder joint. In fact, he was describing exactly what we've measured to reduce spine load and make a very efficient walking pattern. And then, of course, they would surprise attack in the morning and expand the empire. But, these are all such interesting stories that even 2,000 years ago, they understood the science of spine hygiene and better movement.
We can now start talking about maybe a prescribed program that someone might do within a gym or within a certain time frame at their house. But we're now more talking about exercise. And that moves us on nicely to chapter 11, which is the core program. So could you tell us why a core program is important for low back pain and what sort of exercises people might want to consider?
Yes, we're now leaving the first stage of getting a back pain patient better. The first stage was to desensitize their back pain, but now we're going on to building their body to create a foundation for pain-free activity. So that's what we mean by a core program, and we're going to have to consider what is the blend of stability and mobility that will best suit the person's demands and their body features. Let me talk about core stability just to start this off. There are some people who say, "Oh, it's not important." That's not what we measure at all. There are three essential, non-negotiable elements of core stability, and if you don't have them, you won't move. So the first one is the principle of proximal stability for distal mobility. Consider a backhoe that digs in the ground. They have to put down what are called stabilizers, which are outriggers that lift the back wheels off the ground and root the vehicle into the ground so it can actually dig and pull distally. That is proximal stability to perform distal mobility and athleticism. And if you don't do that, you won't dig very much in the ground. Your body is exactly the same. Consider the pec major muscle. So it's a uniarticular muscle that crosses the shoulder joint. Let's say you can bench press 200 kilos or 440 pounds. You've got a terrific pec major muscle. But now you're going to stand and push an object or a person. You can only bench press half your body weight and then you fall over. So if you did a one-armed press standing, the limit is actually core stiffness. You will never use your pec major muscle until you have a stiff core underneath it. Consider this. The pec major spans the shoulder joint. So distally, on the arm side of the shoulder joint, it flexes the arm around. But proximally, it bends the rib cage towards the shoulder joint. So if you pushed someone and all you used was the pec major, your torso would twist towards your shoulder, the arm would come around weakly. In other words, it's a very incompetent movement. But if you stiffened the core and locked down the proximal side of that muscle, 100% of the contraction would be expressed distal into arm speed, or it's the same with the hips. The hips generate power. If the spine bends, you leak power and you wouldn't get in a very effective run or jump or whatever it happens to be. That also would be a pain trigger. So why would you move to sensitize the spine and be incompetent in terms of strength and speed? So that's the first non-negotiable feature of core stability. The second one is the torso forms a guy wire system. So the spine is a stack of vertebra. The very first time we watched a spine injury occur under video fluoroscopy, the spine buckled. And it buckled because of inappropriate sequencing of the guy wire system around the core. So a proper guy wire system allows the spine to bear huge loads. In fact, we've had two lifters now set world records in squatting. And a big part of it is building a core of iron, so that stack, that curved stack of vertebra, from an engineering point of view, you're containing the thrust line down through the spine, and a very robust guy wire system is needed. So that's the second non-negotiable point of core work. The third one has to do directly with pain. At any time you have an injury in the body, it creates a joint laxity. So if you consider someone who's damaged their knee ligaments, for example, the drawer test will show if the joint is unstable and if it's creating a pain trigger. The shear tests of the spine will show exactly the same thing. So if someone has damaged a disc a little bit, it's a little bit flat, that joint will now have micro movements. Those micro movements may be the source of pain. But immediately you experiment with the patient, performing different types of muscle bracing strategies, and you will find the tuning that forms the right girdle to take the micro movements and their pain away. So then that becomes a strategy that they use when they're going to cause pain through an offensive task. They know how to mitigate that by creating appropriate stiffness. So there is the essential non-negotiable elements of core stability. It has nothing to do with transverse abdominis and all this other stuff that some physical therapists propagated over the years. It's much more than that. Then what's the best way to build that stability in someone who has back pain sensitivity? We found what we call the big three exercises to be the very best way. The modified curl up, the side plank, and the bird dog exercise. And when you measure that, they add a residual stiffness that lasts in some people an hour or two. You will run faster after creating that stiffness. You've got more proximal stiffness to unleash the hips. Some people have immediate pain control after doing those exercises. And if you're one of those people, I would suggest do those exercises mid-morning and midday, and you will get 2 times to assist in desensitizing it. Anyway, there is the first discussion of tuning the body for a little bit of stiffness and stability, but then you've got to have mobility if you're going to reduce mobility in the core if that's the pain trigger. So then more mobility at the hips and shoulders. But again, a few tests will reveal if the mobility is part of the pain trigger. For example, some people may report, oh, I've got tight hamstrings. I've been stretching my hamstrings for a couple of years, but I still have back pain. I still feel tight hamstrings. And yet when we assess them, they don't have tight hamstring muscles. They have tight sciatic nerves because of something going on in their lumbar spine. And when we stop the hamstring stretching and deal with the original mechanism in their back, after a brief period of time, their hamstrings start to loosen up. So anyway, there's an example of appropriate mobility. I can give another very fine example with the psoas muscle in the front. Long-term back pain, and we've documented this, tends to inhibit the gluteal muscles and facilitate the psoas, not the iliopsoas, but just the psoas. Then when we stretch the psoas to give a bit more mobility, we use different techniques to prove that some people have a very strong fascial connection through the lateral and frontal chain of their body, so that certain arm movements will actually change psoas tension. But we do a test to see if they have this connection or not. And if they do, then the stretch isn't only a hip stretch, it has to be coupled with specific arm movements. But if they don't have that connection, it really doesn't matter. Anyway, there's just a little bit of a start in the whole world of tuning a body to remove the pain.
And the next question sort of moves nicely on from that, and that was, as you touched on in the core program answer, in chapter 12, you talk about restoring the hips. So I guess sort of the two same questions: why are the hips important for low back pain, and what exercises or movements might people need to consider to be able to restore sort of a pain-free back?
Well, first of all, it won't surprise anybody that the studies have shown very well that people with stiff hips tend to get more back pain, and the reason is they have to use their back more because the hips are not performing what they're meant to do. Then all kinds of considerations then come into play. What kind of hip function does the person need? Do they need to deep squat, or is there other movement tools, perhaps a lunge, for example, that they could employ to avoid the pain trigger? So there's a bit of an emphasis right now, because I think of social media and things like that, where the deep squat has been a test of hip mobility, and yet When you watch a basketball player play, a footballer, a hockey player, it's actually hip internal external rotation. Golf would be another example where it's hip internal external rotation that determines how much stress eventually goes into the back. So restoring the hips, we would probably start more with internal external rotation than we would with the deep squat. And then the deep squat is very dependent on the hip anatomy that they have, whether they have a deep socket or a shallow socket, and that's easily assessed with the being on all fours and rocking the pelvis back towards the heels, for example. But anyway, there's a little bit of a start on restoring the hips. I did mention earlier that chronic back pain tends to inhibit the gluteal muscles, and people become hamstring dominant. For example, when they get out of a chair, they use glutes. They forget to use their glutes and use more hamstrings, which again is problematic for some people, and they wonder why they have more interior hip pain. But when you extend the hips with the hamstring muscles, the line of action tends to push the femoral head into the front of the hip socket for more impingement, whereas a more gluteal dominant strategy tends to pull the hips posteriorly, and it will relieve the impingement somewhat. But anyway, all of that depends on the assessment, and many clues there on how to tune the hips.